G'day, it's Paul McNamara here. Normally I do this session in a room with humans and it's an interactive chat really, but on this occasion I'm doing it as a YouTube video just in case for whatever reason we're unable to get together in the same room. The session's called Self-Compassion and it's about surviving and thriving in emotionally taxing work environments. As you can see, there's these 6 segments here: definition, data, strategies, jargon, clinical supervision and support. I'll work through those, not necessarily in that order. And if there's anything that pops up in here that you'd like to read more about or find out about the references, either use that QR code on the right hand side there or grab that web address and that will take you to the spot where all the references and further reading is. With no further ado, let's get cracking. So first off, a definition around self-compassion. I really like this one from Australian authors, that self-compassion is being empathetic and understanding towards oneself as you might to a close friend in times of suffering. So it's a really nice, gentle, kind thing to do, but instead of directing it outwards, we direct it back to ourselves. And the lovely recognition here, I guess, from the other authors, Mills, Wand and Fraser, is that it could be argued that nursing care is synonymous with compassion, but most likely people think of nurses being compassionate towards their patients and others, not necessarily towards each other and themselves. And this is where I really want to change the emphasis. This session, this iteration of this session, I've been doing it for over a decade now, and up until now I've been talking about self-care, but self-care are more about tasks, I think, whereas self-compassion is more of an attitude or a mindset, and that's what I'm really hoping that you'll take away from this session, is that I should adopt a mindset of self-compassion. If we have a look at some of the data, it might explain why I think that's the case. So this is what happened at the hospital that I worked at in over January and February in particular. So the Queensland borders were opened on the 14th of December, and you can see there that it took until the new year until cases really started turning up in hospital in significant numbers, and then once they started arriving, they arrived in a real hurry. So by the time we were up around the 20th, 25th of January, around that mark, we were getting a bit scared, a bit overwhelmed. We had over 80 people in hospital. We had 3 wards completely dedicated to looking after COVID patients, and as you can see on that green line grumbling along the bottom, there was a fair number of people in ICU too. Fortunately, we're all really pleased that the wave crested in late January and dropped away nearly as fast as it arose. So that was really encouraging. You can see here on the right hand side of the graph there, that's one of the nurses on the respiratory renal ward surfing her way across the Omicron wave. But look, I don't want to get too melodramatic about it, but it was a tense time. It was a tense time for all of us, particularly in those first 2 or 3 weeks in January when we were watching these numbers explode, just really wondering whether we were going to keep on keeping up. It was a difficult time, and the nursing team, and well, in fact the whole healthcare team at the hospital, did themselves proud by keeping up with it, but it wasn't without its anxious moments. It's interesting when you look at some of the data around what's happened with the COVID. The first large-scale survey on trauma, burnout and post-traumatic growth amongst nurses was done, understandably enough, in China. They were the first cab off the rank with COVID. But it's interesting when they interviewed, I think it was over 1,200 people. Don't trust me on that number. Look up the reference yourself. About 13% of the people who were screened described post-traumatic stress type symptoms. Yeah, so that was fairly significant. But interestingly, when you look over there onto the right, a number 3 times that number described actually post-traumatic growth. They actually found being challenged and put in that really difficult circumstance that they felt that they came out the other end of it feeling a little bit better about themselves. So stress does not necessarily mean feeling overwhelmed, but it does challenge us, and some of us, it's going to be a bit more than we can comfortably handle. That's what post-traumatic stress is about. But let's not dismiss that being under stress can also give us growth. And I think for I'll speak to the nursing team on the respiratory renal ward in particular at the hospital. I think a lot of them would describe both the symptom of stress, but also growth. They're a pretty cohesive nursing team. They're really proud that none of them actually caught COVID at work during that Omicron wave. And so they're rightfully proud of how safe they kept themselves and each other. And I think, from the outsider looking in, I think that team is probably more cohesive now than it would have been before they confronted that wave. This is an Australian study this time around, which was only published at the beginning of 2022, so it's nice and up to date. And it was looking at nurses who were exposed to the pandemic, mostly down in northern New South Wales and the southeast corner of Queensland, I think. But anyway, interestingly there, when we have a look at this, so as you can see, blue is for depression, purple is for anxiety. The majority of people, the vast majority of people, didn't experience abnormal symptoms of depression or anxiety. They made their way through it. But there was enough there who experienced mild, moderate, severe and extreme symptoms of both depression and anxiety. That's a bit of a concern where for depression, it's over 25% of people experience depressive symptoms, and for anxiety, it was just a bit over 20% of people experience anxiety symptoms. So we are in the firing line, and we just need to keep an eye out for ourselves and each other. This is the most depressing bit of data you'll ever see. In this chart, boys are blue and girls are green, and I'll start by drawing your attention to the right-hand side there, the other occupations, and we'll have a look there with the males and other occupations. Males and other occupations and medical professionals, they take their own lives at about the same rate. So male doctors and males and other jobs have a really similar rate of suicide. So this is Australian data collated between 2001 and 2012, so before the pandemic, but nevertheless, we can take some learnings from this. Male nurses take their lives more than males in other occupations, about 52% more likely to suicide than males in other professions. So that's a significant concern. Now we'll turn our attention to the green bars, to the women, and again, so we'll have a look at that bar on the right hand side, women in other occupations, and then female doctors. Female doctors suicide at about twice the rate of females in other professions, and female nurses and midwives, when we look over there on the left hand side, they take their lives at about 3 times the rate of females in other professions. Now this is a big deal, obviously. It's a significant concern, and this study didn't go into the reasons why, but we can speculate, I think. Some of it would be the nature of our work is that we get exposed to other people's trauma. We do shift work, that's not great for your mental health. I think there's probably something that we need to take ownership of, is that the psychopathology of nurses and midwives is that they are thought to be compassionate towards others and have lots of empathy. The trouble with being an empath is that you might put the needs of others before your own needs, and I wonder if that's part of it too. I'm sure there's other things that are contributing to that I'm unaware of, but you could stop and imagine and chat about that yourself and just speculate what makes us so vulnerable. We know how to get help. I guess we also know the sort of things that are lethal more than the general public too, but it bugs me that we know how to get help, and obviously we're not doing that at a high enough rate to keep us safe as a profession. So moving away from that really depressing data, let's just start thinking about some of the stuff that we confront day to day at work. I really like this. This is from a guy called Ian Miller. Ian was a nurse educator down in ED in a hospital in Canberra, and he used to have a terrific blog called Impact ED Nurse, or Impacted Nurse, depends how you read it. And then after that, he had another blog called The Nurse Path. He's retired from work now, and so he's retired those blogs, but you can still find them if you use the Wayback Machine. They're worth checking out. Anyway, one of the things that Ian had on one of his blogs was this, that ring theory, that care goes in and crap comes out. And I really like it, and I've been using this diagram with Ian's permission for, I don't know, I'll say 10 years, that'll be close. And yeah, and I really like that he's put the emphasis where it belongs. It's with the patient and their family and close relatives. But also includes us, nurses, and other members of the caring team in there too. So those of us at the bedside also want some care coming in, and also need an avenue for some crap to come out. Hopefully the band around us, that outer band, the nurse educators, our managers, our colleagues, our friends, provide that care going in and an avenue for some of the crap to come out. And if not, maybe we should be giving them a nudge to give us that hand. Hey? So yeah, care goes in, crap comes out, and we're part of that. The ring theory is that care always needs to go towards the centre. And if we can pick up some of that care on the way through for ourselves, so we should, because we need to be able to sustain our work for more than one day at a time. Next little thing I want to introduce you to is this word lalakesia. Is how it's pronounced. It's from the Greek, lalo for language, kesia means shit. So shit language is how you could say it. Lalakesia, I think the dictionary definition is the emotional release you get through using foul language. And I wanted to introduce you to that because I'm from Adelaide originally. I've been up here since '95. But one of the things I really noticed when I first moved up here is that it's a really sweary place compared to Adelaide anyway. And but not all of that swearing is abuse. Sometimes it's this, sometimes it's lalakesia. And the example I'll give, here comes some swears coming up, will be somebody saying, oh, can I just get the fucking pain relief for my fucking pain? It's really fucking uncomfortable. I've been waiting fucking ages. And none of that's abuse. It's people just expressing their distress. And we don't want to get too carried away shutting down people expressing their distress. There was a study done where they got a big bunch of people, they got them to plunge their forearm into a slurry of iced water and asked to hold it there, be stoic as long as you can, but just be quiet and stoic and don't yell or scream or shout or anything. Anyway, so they did all of that. Then they went away, warmed up their arm, and came back and repeated the experiment. But this time they were encouraged to yell and scream and swear and shout as much as they liked. And when people were able to do that, they were able to tolerate having their arm in that slurry of iced water for nearly twice as long as they did when they were being quiet and stoic. So sometimes when somebody's talking about getting their fucking pain relief for their fucking pain, maybe they're just using lalakesia, and we don't want to take that away from them too much. I'm not suggesting that you should be abused, anything but I also don't think you should be oversensitive to people using foul language. And also, it's a good thing to put in your notes when somebody's been swearing a lot on your shift. You can say, Mr. Wilson was especially lalakesic this morning. You might remember these words from your mental health subject at uni. The language of psychiatry was all made up about 100 years ago, mostly by Austrians, and they would speak about transference and countertransference. So transference is when the client comes in and for whatever reason seems to transfer all these feelings they have from somebody else onto you. Usually this is a subconscious thing, but they'll come in and they'll either be openly hostile or maybe even flirtatious or something, just a disproportionate reaction to you. And we think that's a subconscious process going on for the person where they're transferring the memory of another onto you. And it might be simply the way you talk or the way you've got your hair done that day or something. You remind me of, you know, dear old Aunt Molly, and I've always felt very fond towards her, and that's why I'm responding to you this way. That's the theory behind transference. What I really wanted to bring this up for, though, is to acknowledge that we too, before we became nurses, we were humans, and some remnants of our humanity remain, and so we have countertransference. So sometimes we will respond to somebody with either, you know, really, you know, find them really difficult, or sometimes we're especially fond of them and we're going that extra mile that we don't do for other people, and we just need to keep an eye on that. It's not unusual, or it's not even unprofessional for people to experience countertransference, but you just want to be conscious of it. And if you're noticing that I'm treating this person in a different way that I would normally treat the people in my care, it's worthwhile just stopping and reflecting on what's going on for me here. What is that countertransference? See if you can give the emotions that you have in your countertransference, see if you can name those emotions. It'd be a good idea to bounce it off a trusted colleague. Say, oh, I've just noticed myself, I got really snippy with that bloke in room 3, and normally I want to do that, and I wonder what that's about. You know, and try to reflect on that and understand it. But it's really important that we acknowledge that we have countertransference too, and it's our job. We're getting paid to be there. We're on the boss's time. It's our job to be the health professionals and not just let it all blurt out. That's the idea of just reminding each other that we have transference and countertransference at work, and it's our job is to manage our countertransference. We won't very often be able to manage the other person's transference, unfortunately. This bit here is around de-escalation and self-preservation, and I guess I'm just sort of thinking around that transference, countertransference scene. If somebody's being openly hostile, you want to de-escalate if you can, of course, but we don't have to learn a new model for this. You already know your way around basic life support. And if it's dangerous for you to be stepping forward, don't. If you're able to get them to respond to your intervention, that's great. But if not, go to the next step and send for help. Part of that de-escalation and self-preservation thing is to recognise that my countertransference today might be such, or something, maybe there's something else going on in my life today, is such that I probably shouldn't be the person intervening with this, you know, irritable patient or this agitated person. If you're unable to do that, it's okay. It's okay to tap out and say, I need a hand for this. Not just phone security, but also I don't really want to be the one leading this attempt at de-escalation. I've got to preserve my own self here, and I really don't want to make a mess of it. So that's a bit there about the jargon stuff. I want to introduce you to something you may have heard of, which is called clinical supervision. It's coming our way, and it's really important, I think, that you get a good understanding of it. Clinical supervision sounds like scrutiny, but it's not. It's something quite different. To explain, let me tell you this story about the Pithead bath story. In Wales in the early 1900s, there were lots of coal miners mining coal, and at the end of their shift, they'd come home covered in coal dust and muck and whatever else goes on in mines, and then they would trudge home to their little miner's cottage and would be filthy, and they'd get home and they'd change out of their clothes and have to wash their clothes and have a bath and da-da-da. And it added on, you know, probably an hour or so at the end of every working day, and they were using their own hot water, and it was taking them away from their families and da-da-da. And it was just one of the real, you know, painful parts of being a coal miner in Wales at the time. So they got together and they had a bit of a chat about it, and they said, well, really, if we're getting grubby on the boss's time, shouldn't we get cleaned up on the boss's time? And all the miner was like, yeah, that's a good idea. So they got together as a union and took that idea to the mine bosses, and the mine bosses went, oh no, we can't possibly do that, we'll go totally broke. And so these guys went on strike. and they stayed on strike for months and months and months. Some of those Welsh coal mines were shut down for over a year, and eventually at the end of it, the mining bosses agreed that it was fair that if you're getting messy on the boss's time, you should get cleaned up on the boss's time. And so now, or since then, part of the infrastructure of mines in the Western world anyway is that they have what's called these pithead bars, where you've got equipment there and hot water there, so you can get cleaned up on the boss's time. You leave your dirty overalls behind, and the boss arranges for them to be laundried, and then you go home and all nice and clean. But it's important that we remember that we do that on the boss's time, not on your own time. So it's not at the end of the shift, it's actually part of your paid time. You might recall from the Beaconsfield miners a few years ago, and they were underground for a fortnight, those two guys. And I remember seeing on telly, it was on morning TV, that it had been announced that they'd been released from the bit that they'd been trapped in, and but it took them ages before they actually came out of the mine, and that's because in part of the infrastructure of the mine, before they actually left the mine shaft, they stopped and shaved and showered and shampooed and changed clothes, and then, this is what this picture is, then they clocked off after they got out of the mine. So that's a kind of amazing thing, isn't it? When you think of the mining industry, it's a big, buffy, burly blokes industry, but they do a really nice job of looking after them. They kept them clean. You get cleaned up on the boss's time, which that doesn't really happen for us, or so far in nursing anyway. We don't get covered in coal dust and stuff, of course, but we do sometimes get exposed to all sorts of body fluids and what have you. But also we do skill-based labour and knowledge-based labour, but we also do emotional labour, and we get covered in the emotions of others. Think about the people who are experiencing the worst days of their lives when they're in with you. We're there when people die, and we're there. We support the family during that time too. So there's all these emotional things which, if we pretend that didn't affect us, we would be probably somewhere between delusional and completely lacking insight. Of course they affect us. And that's not a new idea, it's not a new discovery. For a long time in mental health, we've had built into our role that we're able to access clinical supervision should we seek to. It's not mandated, but anybody who wants clinical supervision is entitled to get it. And that's been in place for over a decade now, since 2009, with that updated version of the Clinical Supervision Guidelines for Mental Health Services. And that one explicitly included mental health nurses. A previous version took mental health nurses out of it because they thought there was too many of us and it'd be too expensive. But anyway, they realised with a little bit of a nudge that that was a silly idea. So that's been available to people like me, a mental health specialist mental health nurse in Queensland, since 2009 and before. In April 2019, the Australian College of Mental Health Nurses, together with the Australian College of Midwives and the Australian College of Nursing, put out this joint position statement. And in short, it said that clinical supervision, that stuff that's been available for mental health nurses, should be available for all nurses and midwives. Nurses and midwives should be introduced to clinical supervision as students, and then once they hit the ground at work, they should be able to access that as often as required. And that kind of sparked a bit of a conversation. And I'm really pleased, thrilled to be honest, is that in 2021, in the first half of 2021, the Office of the Chief Nurse and Midwife for Queensland Health agreed, and this clinical supervision framework for nurses, midwives was released. It's available on QEPS if you want to look for it for yourself, and it talks about that clinical supervision having a bit of a time for some reflective practice that's confidential and is there to help us with our well-being and to help us improve our quality of patient care, should be available to all nurses and midwives. There hasn't yet been education or resourcing rolled out to support that, mostly because of the pandemic, I think, but it's coming. I'm really pleased that it's coming. And I'm really pleased to be able to tell you with confidence that it's been coming. I've been talking about clinical supervision this session for over a decade, and I've been wondering whether I was being fanciful or not. But anyway, it turns out clinical supervision is coming, and I'm really, really pleased. It's going to be something that's going to be much better for the workforce, particularly when you think about, go back to that data about the high rates of suicide, the high rates of anxiety and depression amongst us. We need to be doing something different. We need to be doing something to look after the emotional and mental health of the nursing and midwifery workforce. So what is clinical supervision? Well, Bridget Proctor, she's one of the rock stars of it, and people like Bridget Proctor because she described the functions of clinical supervision in this really simple way. So the formative function of clinical supervision is about acquiring new skills and getting confidence with those skills. And so, I guess as a graduate nurse, you might, in clinical supervision, say, oh, look, I just really want to use this session in clinical supervision, not so much to talk about stuff, but can I just practice cannulation with you? I really want to get better at cannulation, or whatever other skill that you're still feeling a bit nervy about. With most of those nursing skills, you've got to do them 3 or more times well before you start feeling confident. So taking that space, and if there's something in particular that you want to improve your practice on, and you're not getting the opportunity to practice up either at work or in the everyday education sessions, you could take that to clinical supervision. The normative part of clinical supervision is about keeping us and our practice safe. We've got all those guidelines, code of ethics, and code of conduct, and the policies and procedures that we all need to adhere to. That's what the normative stuff is about, is making sure that we're practicing within those frameworks. And so sometimes the conversation will come back to, I see that you want to learn, want to get better at cannulation. Let's have a look at the procedure, and let's make sure that not only have you got the dexterity to do it well, but you're doing it in keeping with the recommended procedure. And then the restorative part of clinical supervision is the bit that I value the most, the bit that a specialist mental health nurse values the most, and that's about the emotional restoration, and just acknowledging that we do that emotional labour, and of course it's going to have a knock-on effect for us. And so for the restorative part or the restorative function of clinical supervision, it's usually discussing about some of those either really challenging or joyous parts of our job in a confidential space with somebody that we trust, and hoping to be able to reflect on that and take some learnings from that, and it also gives us a bit of a chance to, I guess, ventilate some of those concerns that we have. So that's a good way to get your head around what are the functions of clinical supervision. The way it works, I have an hour a month with a trusted colleague, and I set the agenda for that hour, and I'm away from the workplace. I don't get interrupted for that time, and I talk about stuff that's impacting on me at work, and we're using that framework. Sometimes it's formative, sometimes it's normative, but I guess for me anyway, the bit I really value is that restorative part of clinical supervision. So taking somebody out for an hour out of work for an hour a month might sound expensive when you think about the whole workforce. And I guess we can go like this with the financial perspective and say, oh, we can't afford to spend money on nurses and midwives just sitting around talking, thinking, reflecting. But it does have a knock-on effect for patient safety. And from that perspective, we can't afford not to. You might have come across already in your career some nurses who have burnt out, who have empathy failure towards patients, who aren't particularly great to work with because they are just burnt out. It would be really good if we could dial back the clock and put those people who are burnt out, if they had clinical supervision available to them all the way through, where they're able to stop and reflect with a trusted colleague on their practice, maybe they wouldn't have never have got to that stage. That's the idea behind clinical supervision. So clinical supervision isn't available to us just yet, but as I say, it's coming, and I can't tell you exactly when, but with that framework already being written, I would imagine within the next year or two, it'll start becoming more available, and probably if our previous lessons with things like the no lift policy and the ratios for nursing, and even going way back to the 80s when I started in nursing, where universal precautions, gloves and gowns and stuff for body fluids came in. It takes 5 or so years for those new innovations to become normalised. So be patient. You'll hear about it in the next year or two, and it might feel strange at first, but in 5 or so years, it'll be the normal, and it'll be good. It'll be good for nursing, good for us. In the meantime, we've got to think about strategies and how we look after ourselves at work. One of the things that I do at work is probably don't use the alcohol rub quite as much as I should, and I use the soap and water more than I have to, and mostly because that gives me an intentional break in between tasks and work at the hospital. So it takes you to a spot. You can't do it while you're walking down the corridor or off to doing something else. You have to stop at the sink. And for me, I stop at the sink, I get the tap running, feel the warm water running over my hands, and that feels good because the aircon's nearly always got my fingers feeling cold, and that nice warm water, get on that squidgy soap, and I rub in the soap. And what I'm really trying to do with that is wash away all the crap and stuff that I've been encountering in the time between my last hand wash, and try to wash that away and let it go down the sink. And then I'll give myself another little squirt, and this time through I'm rubbing in the stuff that nurtures me, humour, teamwork, stuff like that. And then I have a look over my shoulder, see if anybody from infection control is watching. Hope that they are, because I think I'm being really careful and good. And then I turn off the tap, flick the water off my hands, grab a couple of, shake it off, Tay style, grab a couple of paper towels and throw the paper towels along with my troubles into the bin, and I get on with my working day. And so I'm able to punctuate my day with these little moments of mindful hand washing, and I use that time to slow down my breathing, just to clear my thoughts and keep myself from going nuts at work. And I recommend that you come up with some sort of strategy that you can use at work. We do a stressy job. There's no getting away from it. And you need to find a way to de-stress yourself at work on the boss's time. Not by taking yourself away from the workplace. You have to be there, but you need to come up with some sort of strategies. So try the mindful hand washing for yourself if you like. At one of these sessions that I did, one of the graduate nurses spoke about having an especially difficult patient. Her counter-transference towards him was very strong, and she said, he had a nasogastric tube in, and you had to crush all his tablets to get them down the NG. And she said, yeah, I used to just imagine when I was crushing the tablets, I felt like I was really getting rid of some of that anger by pounding and crushing those tablets. And I thought that was a really nice idea on how to get rid of some of that frustration, how to self-calibrate and not take it out on the patient, but take it out on the tablets instead. I'm sure you'll have other ideas and strategies. There's those ones which are, I guess, standard off the shelf sort of thing about taking time for yourself away from work, not always talking about work or trying not to think about it, eating well, exercising, spending time with friends. All of those things are very useful to do. If you haven't already got a strategy in place, I would recommend that you be very intentional about acquiring a strategy soon. You'll need it. And then the last part of this session is about accessing support. And there are times that we're going to need external support. You've probably already been introduced to the Employee Assistance Program. There's information about that on QEPS if you want to read up about it. I think if you just put in EAP into the search bar, you'll come up with that page. Also, while you're on QEPS, sorry, I'll just go back. At the moment, the Employee Assistance Program is provided by an external provider called Benestar. They've been on board as our EAP people for probably 4 or 5 years. And that's away from Queensland Health, so there's some privacy there. It's free. It doesn't have to be about work-related stuff. It's a free, confidential counselling service that's available to all of us. When you're on QEPS, if you put in the words bloody stressful into the search box, it'll come up with this kind of old-fashioned thing. It's been around for about 25 years. It was last updated in October 21, but just talks about the stress reactions that we have. There's information in there for family and friends too, and also some information about some alternative avenues to support. So you can find that yourself whenever you need it. It's called Bloody Stressful. It's a 6-page PDF that you can print off and share as you see fit. And then the other thing that we have available to us as nurses and midwives is the nurse and midwifery or nurse and midwife support line. So that's a 24-hour a day, 7-day a week phone number, and with their website there too. So I recommend having a look at that website or saving the phone number into your phone for when you or a colleague need it. It's available to RNs, ENs, AINs and student nurses as well. So so it's a really good resource, and it's really good to know that that we've got that there available for us specifically. We're paying for it anyway. Some of our APRA registration money is diverted to the organisation that runs nurse and midwifery support. So you've already paid for it. Don't feel bad about accessing it if you need it. I've had really good feedback about NM support. Anyway, so that's everything I wanted to talk about for this session. Thanks for listening this far. And as I say, grab that web address there, that metaphorrn.com grow, and you'll be able to find all further reading about this, or you can use the QR code as a shortcut. That's it. I'll stop rambling out. Thank you.